Good afternoon, and thank you for coming to listen to my talk. I'm a little bit of an outlier at this conference. I'm not from medicine. I'm not from rural or remote. I'm a radiographer, but I'm working as an academic at Monash University in the state of Victoria. So my talk is about an observational study which was carried out in far north Queensland. So just as an overview, I'll give you an introduction, the methodology, ethics, results, discussion, and conclusion. Radiographers who work in remote sites, most of the time they have to be dual qualified. They have to have general diagnostic qualification, but also in ultrasound. But they do all of that without the support of an on-site radiologist. Now, medical radiation practice is regulated by the MRPBA, who sets the scope of practice for radiographers. And one of the expectations are that radiographers should be able to identify and convey any significant radiographic findings either to the referring physician or the primary healthcare team. I was seconded by the Department of Health in Queensland to do some workshops in Brisbane, where I met some of the participants and was very enlightened to find some of these radiographers who worked in these remote places and who were duly qualified. And that piqued my interest, and therefore I set about to do this research study. And the main thing was to evaluate how the radiographers are actually carrying out their roles in these remote sites, but also to evaluate what kind of support the radiographers have in carrying out their duties. So the methodology study, as I said, was observational. I carried this out at 2 sites. I can't mention the 2 sites, not because I don't want to, but with the ethics around that, I cannot, for confidentiality purpose, can't name the sites because the radiographers are dedicated to those sites and they want to maintain the anonymity of the radiographers. I had 2 data collection methods. One was a non-participant direct observation, and then I also undertook focus interviews with the 2 radiographers at their respective sites. I did some frequency analysis, which was limited, and that was generated from an observation checklist, and then the focus interviews were transcribed and analyzed with in vivo. So ethics for me, where I had to prepare the ethics application, and I've never had to prepare anything where there's a high population of indigenous people. It was challenging. The first thing I needed to do was to get consent from the 2 mayors from the sites that I wanted to visit, and that was something totally new that I was not aware of. But once I obtained that, I also got ethics approval from the far north Queensland as well as Monash. Needed to get site-specific approval, but also signed consent from the 2 radiographers. The patients that were observed on the 2 days that I visited, the consent was obtained by Indigenous healthcare workers. So I observed 24 patients over those 2 days, with the majority being Torres Strait Islanders and then Aboriginal, but there were also mixed and Caucasian patients as well. So for general x-rays, there were 11 x-rays that were performed. And x-rays, extremities, chest and spine, that's quite common. But having a dental x-ray done in a remote site without any dental equipment, not an OPG in sight, or those little films they put in your mouth, the radiographer had to use a normal 18 by 24 cassette to actually take a dental x-ray, and did a very good job of that. That's something you will not experience quite often, probably never, for most of the radiographers. There were 16 ultrasound examinations, with obstetrics taking most of that. But if you look at and that was just over the 2 days, they had to do obstetrics, upper abdomen, breast, and hand. So the radiographers, who also provide sonography, they have to be generalist sonographers. They have to be able to undertake all of those examinations because there's no one else to call upon. It was interesting around the communication. Most of the patients could understand English, but if there were complicated instructions, and especially with Torres Strait Islander patients, Creole was used. So it was important for radiographers to know some of the phrases that they needed to explain in Creole, but then also some of the regional dialects. Some of the themes that emerged from the interviews I had with the radiographers were around communication, their roles and responsibilities, interprofessional relationships, the support, the off-site report that I have from radiologists, advantages of working at remote sites, but also the challenges, and then some issues around education and training. So from my direct observation, patients were observed as they went and had their imaging done, which was referred, and I observed radiographers in their normal role, so I didn't interfere with anything. Everything that happened would have happened without my presence there. What was really interesting was the rapport that the radiographer had with the patients, and especially with obstetrics, where many of the patients were returning patients, and they knew the radiographer. And it's important to note, both of them were male radiographers, and they had to do transvaginal scans. And that can be very difficult in the indigenous population, and it's there that the indigenous healthcare workers advocate and inform the patients that this is going to be a male in preparing them for those examinations. And then with the communication, apart from having to use Creole sometimes, they also used regional phrases, which was very different to what I would have been used to. Something else which I noted was they had extensive talks with the patients to try and justify examinations. And these talks were in the yarning style. Radiographers, patients come in and out as quick as possible. This wasn't happening because it was important that the patient could understand what was expected from them. But that also informed the clinical decision-making for the radiographers, because quite often they went on, they did additional views, or might complement a general X-ray with ultrasound. They also took on an educative role, especially again with obstetrics, where patients had to come back maybe for a morphology scan around 20 weeks or a third trimester scan. But the other important thing was they really stressed discharge instructions so that patients could understand why it was important to come back so that they could comply and that they could be monitored if necessary. Observing the radiographer within the healthcare team, the support that they got from the indigenous healthcare workers was quite obvious. At the one site, for example, we were looking for the indigenous healthcare worker, and he said, oh, he's gone to fetch the patient. The patient hasn't arrived yet, so he knows where that patient stays, and within a couple of minutes, the patient was here. So they assist with compliance as well. In terms of conveying radiographic findings, when they found something that was acute, that was verbally reported either to the referring physician or the midwife. And the way that they documented their findings, with ultrasound, a technical report was uploaded with the images, of course. With general X-rays, they did not upload any of the radiographic findings. They uploaded the images as well as the referral. If there was something on the general X-rays where they felt that the referring physician should know, that was done via email or direct verbally. The structured interviews, the way that they adapted the communication style, for example, I'm quite sure all of you might have had a chest X-ray and you would have asked to take in a deep breath. The patients don't always understand that. So for the adult patient, quite often they would say, all the wind needs to go inside. And when it's the pediatric patient, because they are water babies, they swim a lot, they would say, take a breath like you are diving for a crayfish. And they would understand that. The other important thing was being aware of physical cues. For example, if you try to elicit a yes response, you don't get a verbal yes, but there could be a raising of the eyebrow. So it's important to observe those physical cues, otherwise there can be miscommunication. Some of the enablers to communicating their findings: one of the radiographers attended clinical handover meetings, which he said was most beneficial because that gave him the full complement of the patient and having all the other medical people there to discuss the patient, but he could also provide his opinion at that point. The main thing was the collaborative approach. The patients are important. It's important to come to a decision that is best for the patient, and therefore direct communication between the radiographer and the team is quite evident and also important. But it's important that the radiographers are very clear in what they are conveying, because they are not radiologists. The radiologists are the experts, and their reports are final. In terms of roles and responsibility, you've seen just with that little bit that I've shown you that the clinical imaging service that they provide is very broad, and they say they're jack of all trades, but I say they're master of many, because what they did was really good. And apart from the clinical imaging, they have to manage everything else. They have to do the administration of the patients, arranging finances if equipment needs to be replaced, writing business cases, for example, to get imaging services at remote sites. But apart from that, they also have to supervise remote X-ray operators. There's about, I think, 6 radiographers at these remote sites, and they are responsible for 40 X-ray operators with very limited training. I've already talked about the value of the indigenous healthcare workers and that they can explain intimate examinations, but also there's lots of dialects, so they can be helpful in translating some of the instructions to the patients, but they also assist in breaking down some of the cultural barriers from the indigenous population of understanding why they need to come to imaging, but also from the medical imaging team understanding things like taboo times and having respect for that. In terms of communication with referrers, quite often they needed to modify referrals because they were poor. They would not just do it, they would go to the referrer and say this would be a much better examination to do. And then also with the local doctors. They are very experiencing in rural and remote medicine, and it's really a collaborative effort between the doctors and the radiographers. In terms of the radiologist support, as I mentioned, they're not on site. Quite often the acute cases are managed before the radiologist report is available. With general X-rays, these are reported via teleradiology, and they've actually got a very good reporting rate. They said it's about 98 to 99%, with a 24-hour turnaround of 65%. But there are plain X-rays where something like a fracture is not evident, and there could be a soft tissue sign like lipohemarthrosis, which the radiographer can recognize, and that is an indication of an occult fracture. With obstets and gynae, they have a very experienced team of radiologists with whom they have close contact with. So if they have a case where they are unsure, they would call them up and send the images through as well. So some of the advantages for radiographers working in these remote sites is they see pathologies that are complex, that they would not normally encounter. They are very much involved in the management of the patient, so they know what's going to happen to the patient. But the main advantage for them of having medical imaging at remote sites was the reduction in do not attend rates. That has reduced significantly from previously. The challenges I've mentioned already, having support for administrative work, and then recruiting dual qualified staff. That's really difficult for someone who has done diagnostic radiography and then ultrasound and then to go and work in a remote site. You really need a passion to be able to undertake those imaging at those sites. In terms of education and training, it's important that staff who will be employed to these remote sites are trained, because the sites are complex. Radiographers are not always used to providing an opinion. They are not always used to managing something differently. Some of them are not even used to making appointments. And then for radiographers working in these remote sites, to try and get relief to be able to attend CPD or further education. Before there was a relief pool, now they have to source their own relief, and that's very difficult, especially if you need to keep up with your CPD activities. One suggestion was to try and attract more radiographers to these sites, is to consider having clinical placement for senior radiography students. That will allow them to experience the scope of running a medical imaging department, but also the less common things like the dental x-rays I mentioned. Facial bones, for example, most hospitals go straight to CT, and they don't do plain x-rays anymore. So from my observation, it was clear that there is unique interactions between the radiographer and the patient, but also with the healthcare team, very close collaboration with the interprofessional team, and with the absence of on-site radiologists, the local doctors often use the radiographic findings as their first port of call. And just one case that I saw on that day, she had a scan at 10 o'clock. She was 28 weeks pregnant, but her cervix was wide open. The radiography immediately got the midwife. She was evacuated. We were on the ferry about 4:30 when the radiologist called and said, "What happened to that patient?" The patient was already being treated at a regional hospital. So remote radiographers work under challenging conditions. It's complex, but the main thing is that they do influence immediate patient management at the point of care. Thank you. I've just got one more thing to say, which has got nothing to do with my talk. And I've left some flyers there. Is between our university and the University of Newcastle, Department of Rural Health. We are interested in developing an online graduate certificate in X-ray image interpretation, but need to establish whether there's really a demand for that. So the handout has the website or the QR code that you can scan and do on your phone. There's only 4 questions. It takes less than 2 minutes to do that. And I really would appreciate if you would either go to the link or use the QR code. Thank you very much. I'm not sure if we've got time for that.